Hello, thank you for joining us for conversations, cases, and updates in myelodysplastic syndromes, practice-changing expert insights. During this segment, we'll be discussing updates in the diagnosis and risk stratification of MDS. I'm Rami Komrokji from Moffitt Cancer Center, joined by my dear colleagues, Dr. DeAngelo and Dr. Mikkael Sekeres. So I thought to kick off this, I'll share with you three cases that I saw to highlight some of the challenges in the classification and risk stratification, how those patients can present to us clinically almost the same. But when we look deeper into this, that, the classification and the risk stratification that ultimately leads to the management is totally different. So over the last year, I saw three cases. All of them were in their 70s, presented with some cytopenias, and they ended having, obviously, evaluation. The first patient actually had a bone marrow by the referring physician almost 6 months before, and the bone marrow showed ring sideroblasts. So the patient was labeled as MDS with ring sideroblast and was started on hypomethylating agents treatment and was still transfusion dependent, so came back to see us. So we repeated the bone marrow. It did show ring sideroblast. However, there were no mutations observed. And we ended actually checking copper levels for that patient, and all what the patient had was copper deficiency. So this is a case that highlights that not everything we see on the bone marrow is really, especially the ring sideroblast, can be, sometimes there are diseases that can mimic MDS and can look like MDS. The other patient actually did have a bone marrow at our center, and it did show MDS ring sideroblast, SF3B1. It was a classical, MDS with ring sideroblast SF3B1, and the patient had a trial of ESA, was not responding, so we moved to luspatercept. The third patient also had the same profile, cytopenias. The bone marrow showed ring sideroblast, but the myeloblasts were around 9 to 10%, if I recall correctly. And that patient had a complex karyotype, a biallelic P53 mutation. So obviously the management is going to be very different. So I think those cases just highlight, the diversity of the disease that we see and the heterogeneity, and that, the clinical phenotype sometimes could be looking similar. There are diseases that mimic MDS, and even in the MDS, obviously the spectrum is large from somebody with lower risk disease to a higher risk disease. So this comes timely, I think, as we've been, dealing or working with newer classifications for MDS. So this year we heard about the new WHO classification and the ICC classification, and also a new prognostic models that incorporate molecular data. And, just to briefly summarize, I think, there are some differences between the two newer classifications, but I think the theme is we are starting to integrate molecular data. So now we have genetically defined groups of MDS. We historically looked at deletion 5q as, genetically defined. Now we have SF3B1 and we have P53 as genetically defined. And also we are refining a little bit the morphologically defined groups. So like the WHO introduces group like MDS with fibrosis, hypoplastic MDS, the cutoff, for like the ICC still recognizes the presence of multilineage dysplasia, etc. So the classification is changing, but basically the main, take-home message from it is that we are recognizing molecular entities probably, and not going through the discrepancies. On the same hand, we have several models that were proposed for prognosis. Probably the one that gained most momentum is the IPSSM that retains the IPSS revised, variables, including blood counts, myeloblast, and cytogenetics, but incorporate molecular data. And it turns out the strongest predictors of outcome are mutations such as like P53, FLT3, that's rare to happen in MDS, and a mutation that's usually not even set yet on the next-gen sequencing that's done in practice, the MLL-PTD. But the model, changes this staging in almost half of the patients, with like 10% of the patients staged one stage or more. At last ASH, we heard several groups presenting validation for that. So maybe I'll start asking some questions like, Mikkael, what's your take on the ICC, WHO? You've been closely involved in this as well. So,
yeah, thank you, Rami. That's a beautiful overview of all of this. You know, a lot of us in the MDS field are grateful that there are so many different classification schemes because it's resulted in about 5 to 10 publications now trying to figure out what we should believe. What what I've noticed, I think you summarized it well. If we're trying to be thematic about it, these classifications are now increasingly recognizing the importance of molecular abnormalities and calling out specific subgroups with those molecular abnormalities. So in the WHO classification, we now have a call out in addition to patients who have a deletion 5q abnormality, which has been around now for about 2 decades in WHO classification. We now have those who have SF3B1 abnormalities and biallelic TP53. If we look at the ICC classification, again, we see a call out for SF3B1 and deletion 5q, but now not as much attention to TP53. So it's great that they're recognizing these molecular abnormalities. I just wish that they were recognizing them with respect to their prognostic importance. Obviously, patients who have a TP53 abnormality, particularly a biallelic one, have a very poor prognosis, whereas those who have an SF3B1 mutation in isolation actually have the only good prognostic mutation that's available. So when I look at them, and try to make some sense of these, to be honest, I look at the ICC classification and I basically see a recapitulation of the former WHO. We have those patients who have SF3B1 mutations. Those are those who had ring sideroblasts in the past. We have deletion 5q, single lineage, multilineage dysplasia, and then excess blasts. The curveball that we were thrown, which is not a surprising curveball, is that there's now a category for MDS AML overlap for those patients who have 10% or more blasts. Now, this is not a surprise that this group would be called out. When we were developing the revised IPSS, we found that patients who had a blast percentage that was 10% or greater had the same prognosis, whether it was 10 to 19% or 20 to 29% blasts. Now, I looked back at the supplemental tables to the original IPSS, and it turns out that the same thing held true with the original IPSS, despite the fact that those two groups were given different scores in the original IPSS. So I had gently floated the idea as we were putting together the revised IPSS that maybe we should mention in the discussion section that patients with 10% or more blasts should actually be considered as having AML. Now, we didn't go down that route. We were afraid it was a little bit too cutting edge at the time to suggest that, but lo and behold, here we are a decade later, exactly a decade later from the publication of the revised IPSS, and this is now a distinct subgroup, and I think that's actually the right thing to do. With respect to revisions in the prognostic scoring system, as you've pointed out, we've gone into an era of formally including molecular abnormalities into the revised IPSS. Now, this has actually been done formally or informally for a few years. While the molecular IPSS provides a little bit more accuracy with result to classification for overall survival, it leaves us with a system that is incredibly complicated, particularly for a person who doesn't live and breathe MDS like the three of us do, and who may not have the time to go online and enter all of these data. So I do think there's continued to be a role for the revised IPSS or even the original IPSS to take kind of a rough cut of whether a patient has a lower risk or a higher risk MDS.
Yeah, absolutely. I agree with you. I think, obviously the refinement, reflects some of what we see. I think we are sometimes mixing a classification versus a prognostic system. Classifications are different from prognostication. I think for me, the highlight, and we've presented some data at ASH trying to look at the two systems, is like, there are molecularly defined entities, as you exactly mentioned. So ring sideroblasts without SF3B1, their outcome is actually like MDS, non otherwise specified. Things like multilineage dysplasia does matter in lower risk. And then obviously the issue of the 10% blast, actually, the way I think of it sometimes, I think that we have MDS, accelerated phase MDS, and blast phase MDS. And that biologically for me makes some sense. So maybe I'll ask Dan, since he's a clinical investigator in both AML and MDS, does that 10% cutoff make a difference? And are you going to start thinking of lumping those patients in clinical trials together?
Well, it depends on the regulatory situation, but just before I move on, just to comment on some things that Mikkael said. I mean, I think the difficulty that we're faced with 2023 is the fact that our pathologists have two separate systems, and so they're faced with the conundrum of trying to report, based on both the WHO 2022 and the ICC system, and I think it leads to some confusion in the community. The second issue that I think it deserves some attention is that maybe centers like ours can turn around the molecular diagnostics in a few days so that there is a concordance with the histologic diagnosis and the molecular cytogenetic in order to come with a unified diagnosis, because they're all integrated, as Mikkael nicely elucidated. But that's not the case in the community. You often will have the histology, and then you'll get a week or two delay before you get the molecular and or the cytogenetics. And as you all know, and has been stated by both yourself, Rami, and restated by Mikkael, is that we are leading more to a molecular classification. And so it does lend itself to some difficulty. But back to the question that's asked, I was always taught when I was a first-year fellow, a blast is a blast is a blast, and and blast behave what blasts do. And we've in our phase 1 studies, we've always included blasts that are 10 patients with blast 10% or more, because I'm just looking to see whether this biologic agent is going to be effective, and whether the blasts are 12% or 22% doesn't really matter, because I'm going to get activity. Now, from the regulatory issue on the FDA, and we have a former member of ODAC, it's going to be a little bit complicated, right? When I was a first-year fellow, we called leukemia 30%, and you would see a patient with 25% blast, you say, and it with a little bit of tongue-in-cheek, congratulations, you don't have leukemia, you still have MDS. And of course, then it went down to 20%, and now it's going down to 10%. And it makes sense clinically and biologically, but from a regulatory perspective, it's going to be somewhat complicated in the future. But I agree. I mean, we think of 10% blasts or patients with that range as all in the same bucket. It's just a question of what are you going to use from a regulatory perspective from your armamentarium.
Dan, wasn't it Shakespeare who said a blast is a blast is a blast?
Yeah, in 1620.
Was he in your fellowship class or no?
Yeah, actually, when we look in our data, it's really even above 5%, it's really different biological clock. As you said, a blast is a blast. Once you are having excess blast, the outcome is very similar. Obviously, sometimes, you want to have a cutoff higher than the 5, because then there is variation, because you could count twice and have 4 and 6. So, but
yeah, you're absolutely right. There is one of the variations, and so we all have that. 6% blast by one pathologist, 4% by another. But when you're starting to get into the higher numbers, there's a little bit more concordance in terms of the classification.
Right.
Well, the point that you just made, Dan, though, about one pathologist to another, we've done a study through the NHLBI MDS Natural History Study where we've looked at agreement between local pathologists and specialized central pathologists for diagnosing MDS. And the design of this study is that a patient enters the study when they have a possible diagnosis of MDS, and then after enrolling on the study, they undergo a bone marrow biopsy, and you see whether or not they have MDS, or if they're in a cohort of patients we call at risk of MDS. So something like CCUS, or patients who have a lot of dysplasia, but not quite that 10% number we're looking for in an individual cell line. And what we found is that the disagreement between local pathologists and central pathologists for diagnosing MDS versus leukemia, or MDS versus a vitamin deficiency, so not subtleties of pathologic distinctions, but really big clinically meaningful differences, that disagreement was 27% between local pathologists and central pathologists. Now, when we dug into this a little bit deeper, and this actually makes it even more interesting, half of those disagreements weren't actually disagreements at all. They were coding errors by the research coordinator. So the true disagreement was about 15%, but for major differences, right? Not just was it MDS with ring sideroblasts because they had 16% ring sideroblasts versus 14% ring sideroblasts. Who cares? We're going to treat them the same way anyway. But for actual differences between like MDS and leukemia, things that would make a difference on treatment. So we think this has interesting implications in two areas. One, really the need to have these diagnoses made by pathologists who are skilled at looking at MDS bone marrow biopsies for real accuracy. But secondly, think about how that affects our national registries where we're trying to track patients who have MDS and the accuracy of those registries, or reporting of MDS on clinical trials that may lead towards regulatory indications.
Absolutely. So, Mikhail, another question maybe. So, like nowadays, if you are applying the IPSSM and you upstage the patient from a lower risky group, are you going to act on that? Are you going to treat those patients as a higher risk?
It's a great question, Rami, because the biggest decision we have to make as the three of us are non-transplant MDS doctors, the biggest decision we have to make is when to refer that patient to somebody who is potentially going to perform a hematopoietic cell transplantation on them. And right now, that algorithm is really based on the IPSS, right? So patients who have higher risk disease by the IPSS, we know from a couple of decision analyses, have should be referred to transplant early on. Those who have lower risk MDS by the IPSS should be delayed in that referral to transplantation, even with younger adults. Increasingly, we've been incorporating molecular abnormalities to quote unquote upstage the IPSS or revised IPSS, right? So if somebody has a particularly bad abnormality, like an EZH2 abnormality, but they come in as an intermediate 1 risk IPSS, we might actually consider them intermediate 2 and then refer them to transplantation. So as we've been more and more relying on molecular abnormalities in figuring out the correct prognosis for these patients, I do think we are starting to refer these patients earlier for transplantation. We do so, though, at least from my perspective, with a little bit of hesitancy, because while we know these patients don't have a good prognosis, either standing alone with no therapy at all, and remember, all of these IPSSs were developed based on patients who didn't receive a drop of therapy, or even with therapy, we don't know that that risk is significantly altered once they go to a transplantation.
Absolutely. Yeah, and maybe the last part to discuss during this section is as we talk about the spectrum of MDS, now even the WHO and the ICC, and there is a lot of interest in introducing pre-MDS situations. So now we are dealing also with, CHIP, clonal hematopoiesis of indeterminate potential, CCUS, clonal cytopenia of unknown significance, and the WHO introduces the definition for those, where in CHIP patients don't have cytopenias. In CCUS, patients have mutations, almost a similar variant allele frequency to MDS, and they are at higher risk. Patients with CHIP, actually, their absolute risk is low, 0.5 to 1% per, to progress to malignancies, but with the CCUS, it's higher. So have you been seeing those cases? What do you do? There is really no consensus on how to manage those patients.
So yeah, I don't know who the question was for, but I'll start. I mean, we have a clinic where we're just seeing those referrals, and based on Dr. Ebert's discovery of the clonal hematopoiesis amongst others, but in order to get into the clinic or the CHIP clinic, you have to have an NGS sequencing panel that shows it. And as you mentioned already, these patients don't have cytopenias; they have normal blood counts. There's another reason why they had a molecular diagnostic, either as part of a research study, as part of a mutation assessment or genetic assessment for breast cancer, colon cancer, some other assessment, and somebody discovered that they have, potential for clonal hematopoiesis. And you're right, their biggest risk is non-myeloid or non-hematopoietic disorders like cardiovascular disease, inflammatory problems, The CCUS and ICUS issues, those are patients with cytopenias, either with a clonal aberration or without. And Lachelle Weeks from our group presented data from the UK Biorepository and collaborated with Luca Malcavati's database and our own database here at the Dana-Farber, a small percentage, because as you pointed out, most patients have an excellent prognosis with an exceedingly low risk of developing a hematopoietic disorder. But you can identify a small group of patients where their risk is substantial. And those patients, what do we do with those patients other than watch them needs to be ascertained. But there are some ongoing research venues to try and intervene earlier. But that's a research question right now.
Absolutely. Yeah, and we are establishing the same clinics as well. I think one interesting aspect was like those patients with CHIP, if they get chemotherapy for solid tumors, they are at several folds higher risk of developing therapy-related MDS or AML. So we're trying to do a project with our solid oncology colleagues, because like sometimes in breast cancer, let's say patients are getting adjuvant chemotherapy for an absolute survival advantage of 1%. But if we can come and say this patient has like maybe 5 or 6 folds higher risk of developing therapy-related AML, I think that should be weighed in the decision whether the patient should get adjuvant chemotherapy for a very small absolute benefit. So we're trying to do stuff like that. As you alluded, we are trying to bring some trials for the CCUS higher risk group that have higher rate of progression to frank MDS. We encounter every now and then patients with CCUS that they do have profound cytopenia that needs treatment, and that gets challenging. Many of them get coded, I think, in real life as MDS because they look like MDS. And absolutely. So I think we could conclude this session. Thank you again for joining this segment on update and diagnosis and risk stratification of MDS. And we'll be proceeding to discuss the lower risk and higher risk MDS in the coming sessions or segments. Thank you.